The A002-7 trial I had the privilege to present is a randomized phase 3 trial looking on the intensity and the necessity for maintenance treatment in metastatic colorectal cancer. There is some, let's say, uncertainty whether and how we should use maintenance treatment after standard induction chemotherapy, and we call this induction chemotherapy already, with the fluoropyrimidine, oxaliplatin and bevacizumab. And this trial was the free-arm trial, which looked whether we could allow to de-escalate the maintenance treatment. So a standard arm, we considered the continuation of a fluoropyrimidine plus bevacizumab. As an experimental arm A, we took bevacizumab as single agent, and experimental arm B for us was to discontinue treatment in total after induction treatment of 24 weeks of any fluoropyrimidine plus oxaliplatin plus beva, meaning it could either be 5-FU or capecitabine. The result was quite clear. When we also considered re-induction, meaning after first progression, also re-induction of the initial treatment regimen, because patients were not progressing, we saw that bevacizumab alone as maintenance treatment is not inferior to the standard 5-FU plus bevacizumab, but doing nothing was clearly inferior, so we could clearly exclude doing nothing as an option when we'd like to have this time to failure of strategy as primary endpoint. We also looked until time from randomization to first progression, and this was also, the best arm was clearly 5-FU plus bevacizumab. The second best with a hazard ratio of 0.64 was beva alone, and doing nothing was the worst arm. The hazard ratio favoring the combination was 0.49. However, we failed to show a difference in overall survival. There was no signal. I have to acknowledge that overall survival assessment is quite early this time. We only have about 50% of the events, so something could change. So our conclusion is using the best out of the strategy once chosen means to continue with maintenance treatment, with an active maintenance treatment with any fluoropyrimidine plus bevacizumab until first progression. However, if a patient is not willing to follow this route, or there are some concerns in terms of toxicity, etc., you may also stop treatment and take into account that so far overall survival hasn't differed that much. But to exploit the best out of the treatment, the active maintenance is the best option.